Welcome back to Studying with me for the Nurse Anesthesia Certification Boards. Today I'm going to be talking about acute intermittent porphyria. I apologize in advance for my sloppy handwriting. Hopefully the voiceovers will make up for that. So let's get started. This disorder is a rare hereditary autosomal dominant disorder. Hereditary means that the person inherited the trait for this disorder from at least one of their parents. Autosomal means that the gene that expresses this disorder is located on one of the autosomal chromosomes and not one of the sex chromosomes. Dominant means that only a single copy of the mutated gene is required for the disorder to be expressed in this person. There are two categories of this disorder: acute or inducible, or chronic or non-inducible. Acute is the one that we worry about, or we are more concerned about in anesthesia, because acute is the more common form of this disorder, and it is also the most dangerous form of this disorder. Acute intermittent porphyria is caused by a mutation in the HMBS gene. This gene is responsible for the hydroxymethylbilane synthase enzyme. This enzyme is important for one of the steps in the process of creating heme. With this disorder, this enzyme is defective, so it's not working properly. And if it's not working properly, we can't create heme, and we have a buildup of these toxic precursors or porphyrins that comes before the heme is actually made. At the bottom is a very simplified pathway for heme synthesis. Note where the ALA synthase enzyme is located, because this is an important part of the management of this disorder. So what are the signs and symptoms of AIP? Severe abdominal pain is the most common symptom. Then you have nausea and vomiting. Then you have muscle weakness, specifically skeletal muscle weakness, which could lead to a risk of respiratory failure. Then you have bulbar weakness. The bulbar nerves include cranial nerves 9 through 12. So I try to put some little visual cues in here. Some people do better with visual cues, just to help remember the signs and symptoms of this disorder. As you can see over here, this is abdominal pain with the little lightning bolts coming out there. And then we got a confused looking face, an anxiety face, then sleeping beauty. I tried my best. That's where the coma. And then if we go up, we got the nausea, vomiting. Then we have the angry lungs for the respiratory failure. And then this is supposed to depict some gastric contents in the alveoli. That's for the aspiration. So as anesthesia providers, we need to be aware of the conditions that could possibly worsen the symptoms of AIP or trigger the symptoms of AIP, because as you can see, some of the things that we do as anesthesia providers can worsen these symptoms. Take, for instance, prolonged NPO status. When people are coming in for surgery, what do we tell them the night before? We tell them not to eat after midnight. And this is for good reason. It's for their safety. We don't want them to aspirate abdominal contents into their lungs. We want to minimize the risk of that. But as you can see, having a prolonged NPO status can worsen these conditions. So maybe if possible, they could schedule the patient a little earlier in the day so their NPO status won't be too long, but sometimes you can't get around that. Emotional distress. Of course, people are going to be distressed. If you're coming in for surgery, you're coming in for major surgery, you're going to be anxious. Most likely, I've seen people cry because they're going into surgery. You're going to be fearful, all that stuff. So, that can do it. Stimulation of ALA synthase. I mentioned ALA synthase earlier in the process of creating heme. As you could see earlier, that enzyme is in a step before the porphyrins are made. So if you have ALA synthase and that's working properly, so you have it now making these toxic porphyrins, but the porphyrins have no way of being converted into heme because you have the defective HMBS gene. Now you have a buildup of extra porphyrins because you have the ALA synthase working in overdrive and making those porphyrins, but no way for them to be converted to heme like they're supposed to be. Last but not least, you have CYP450 induction. CYP450s are enzymes that are located in the liver and other parts of the body. They are involved in metabolism, And when you induce them, that pretty much means you make them go into overdrive, make them work more than they usually work. It's important to know about CYP450 induction and stimulation of ALA synthase because some of the things that we give in anesthesia can actually cause both of these things, like barbiturates. For example, we give methylhexatol or Brevitol for ECT induction, so it's good to know, if this patient has a history of AIP, it's good to know because we do use a barbiturate for this particular procedure. What are some things to avoid in patients with AIP? Conditions to avoid are emotional stress, prolonged MPO status. I know that these people are coming in for surgery, so they're going to be stressed. They're automatically going to be stressed. Something that we can do to mitigate that is to give them anxiolytics. Pre-op, we can give them Versed or we can give them Precedex, something that could help with that prolonged MPO status. You may not be able to avoid that. They could possibly schedule the surgery earlier, but that would be up to the surgeon. Medications to avoid would be ketorolac or Toradol, etomidate, amiodarone, calcium channel blockers, birth control pills. We, of course, do not prescribe birth control pills, but it's good to know whether or not somebody's on birth control pills. It's something that we do need to know. Barbiturates, like I mentioned earlier, like Brevitol, different things like that. Ketamine, that's a big one. As you can see, these are things that we use very often, like ketamine and Toradol. We use those often. I don't see people use etomidate that much, but it's good to know that this should be something that should be avoided in these patients. So if you have a patient with AIP, what would their anesthetic management look like? So you want to start with liberal hydration, glucose supplementation that reduces ALA synthase activity, heme arginate reduces ALA synthase activity, prevention of hypothermia, so use your bear hugger, use your fluid warmers, warm up the room, all that good stuff. Safe anesthetics to use in these patients are volatile agents, nitrous oxide, neuromuscular blockers or paralytics, neuromuscular blocker reversal agents, narcotics, midazolam or Versed, ondansetron or Zofran, vasopressors, and beta blockers. They are all safe to use in these patients.